This is an algorithmic approach for triage and transfer of patients of STEMI or PCI. So this is a pathway for triage. So look at STEMI patient who is a candidate for reperfusion. So all STEMI patients are candidates for reperfusion, and let's say we have a patient who does not have any contraindications for reperfusion, and he has got a classical established STEMI. That patient can present either to an initially seen at a PCI capability facility, or he may be seen initially at a non-PCI capability facility. If he is seen at a PCI capability facility, send him to cath lab for primary PCI. This is a class 1 level of evidence recommendation A, class 1 year recommendation. Then pre-antithrombotic anticoagulant plus anticoagulant regimen. So you have to give anticoagulant and then antiplatelet regimen, and diagnostic angiography will be done. Based on the diagnostic angiography, either it may come as medical treatment or PCI or CABG. What are the indications for CABG, what are PCI, what are the indications for medical therapy, we will see subsequently, and also in the lecture that will follow my talk. Whereas transfer for primary PCI, those patients who are seen in the non-PCI capability facility, they can be transferred to a PCI facility who will undergo the same algorithm as those who have attended the PCI, provided they can reach the PCI facility within 90 minutes. If they cannot be transported to the primary PCI facility within 90 minutes, then we must think of initial treatment with fibrinolytic agents, class 1 year recommendation. Then there are two classic types of categories: high risk patients and not high risk patients. Those who are high risk patients transferred to a PCI facility reasonable for early diagnostic angio and possible PCI or CABG in case it is required after the fibrinolysis, because these are high risk patients. They may require a PCI or CABG or any other angiography investigation, so they need to be transferred. High risk patient is defined by STEMI focused update and should undergo cath as defined. We have already seen who are classified as high risk patients. So at the PCI facility, these are evaluated for the timing and the diagnosis of angiography when angiography has to be done. Suppose the patient is not belonging to the high risk, transfer to PCI facility may be considered. It is not an absolute thing, especially if ischemic symptoms persist and there is failure to reperfuse, that if the failure of reperfusion is suspected. So this is in a nutshell the triage of patients who attend the PCI facility and a non-PCI facility with STEMI. Now the problems in salvaging the myocardium. The first problem is the delay on the part of the patient, the time between the onset of symptoms and the emergency call. They don't report to any health facility or call any doctor or any emergency help. That is the delay most important. What is the solution? Patient education, general public awareness about the acute coronary syndromes, their awareness about the symptoms, their need to seek medical help at the earliest. Gas trouble, that way they should not delay the time or waste on other types of self-medications. The second aspect, of course, is the transport delay, the time between the emergency call and the patient is contacted. So that is the emergency service should reach the patient. Patient has called for the emergency help, but the emergency call doesn't arrive in time. And here most of our patients, they use private transport and they do not depend on government transport or emergency medical facility services. Here the paramedic organizations, if they become strong and if there are emergency cells wherein they are trained to reach the facility patient very early, this delay can be cut short. The third important aspect is the delay that occurs in the emergency department after the patient reaches the hospital. So hospital or practice organization has to be strengthened and the protocols have to be made very clearly. Door to needle time, first medical contact to needle time, door to balloon time, first medical contact to PCI. So these are the problems: a patient problem, the transport problem, and of course the hospital protocols and hospital delays. So one has to improve upon all the aspects to reduce the delay and increase the survival chances and use the golden hour. This table summarizes the management of acute coronary syndromes. Supposing the patient has got no acute coronary syndrome and only has got stable chronic angina or chronic stable angina, then all you need to give them is aspirin and beta blocker. No heparin, no ICU care, no thrombolysis, no primary PTCA. If the patient has got unstable angina, that means there are some changes in the ECG, enzymes are negative, pain is prolonged for more than 20 minutes. Such patients have unstable angina. They should be given A aspirin, B beta blocker, C clopidogrel, and also they should receive either unfractionated heparin or low molecular heparin. If heparin is given, 4000 units of heparin bolus should be given, followed by 12 milligrams per kilogram every hour as infusion. Low molecular heparin, depending on the body weight, you have to give enoxaparin. ICU care may or may not be necessary depending on whether the patient is a high risk or a low risk patient. Of course, STEMI and unstable angina do not qualify for any lytic therapy, and there is no indication for primary PTCA in these patients. Elective PTCA can be thought of to reduce cardiovascular morbidity and reduce the burden of ischemic problems in these patients at a later stage, not on an emergency basis. NSTEMI, non-ST segment elevation myocardial infarction, we have to give A aspirin, B beta blocker, C clopidogrel, G, that is the GP blocker, which is epciximab or tirofiban or eptifibatide. One of these drugs have to be given along with unfractionated heparin and low molecular heparin. Either this or this, the preferable agent would be to use low molecular heparin. Intensive care admission is a must because most of these patients have STEMI, they go on to full-fledged or frank through and through myocardial infarction, and they do need direct early conservative, early invasive strategy. They need primary PTCA, and those patients who are shown who are given the option of not early intervention but a conservative treatment, they may not go for PTCA, and there is no question of being lysis using lysis because lysis increases the mortality in patients with STEMI. Then of course the QA myocardial infarction or ST segment elevation myocardial infarction, the classical transmural through and through myocardial infarction, you have to use all the 4 drugs, A aspirin, B beta blocker, C clopidogrel, G of course your GP blocker. The triple platelet blockage and beta blocker are a must. Unfractionated heparin or low molecular heparin depending on the procedure that we are going to choose, and immediate ICU care is essential. Lytic therapy can be tried in those patients who are lytic eligible in whom we cannot do primary PTCA. If lytic therapy is not chosen but the patient is shifted for primary PTCA, and that group should receive primary PTCA. Some of them, they may have lytic therapy then transferred to a higher center where for ongoing ischemia they may undergo subsequent PCI. What drugs do we prescribe after the patient is discharged with acute coronary syndrome managed in the hospital? There are 2 types of information that the patient should be given, one about the drugs, the other about the lifestyle. The drugs, of course, aspirin to be continued almost lifelong, atorvastatin in high doses, not to reduce the cholesterol but to act as anti-atherogenic and anti-inflammatory, and to reduce the improve the endothelial function and reduce the erythematous burden, and of course to correct dyslipidemia too. ACE inhibitors or ARBs are a must in all patients of acute coronary syndrome discharge, particularly those who have hypertension, those who have diabetes, those who have ischemia associated with more than 2 other risk factors, those who have got less than 40% of ejection fraction, heart failure of any nature, and of course patients who are diabetics, A1C control is a must. So these 4 ACEs, aspirin, atorvastatin, ACE inhibitor, A1C control along with beta blocker are a must. Whether you add nitrates to this, whether you add calcium channel blockers, whether you add ranolazine, whether you want to give trimetrozine, it is your choice. But these agents are a must. We cannot stop these agents going, and then of course clopidogrel has to be given, which is not listed here, at least for 1 year. There is no indication for continuing anticoagulation, particularly the parenteral anticoagulation, unless there is an indication for anticoagulation in the form of atrial fibrillation or mural thrombus or any of those conditions, in which case you use warfarin for long-term anticoagulation. Whereas when we come to lifestyle, smoking cessation should be stressed, and this must be achieved. Physical activity slowly should be increased, early ambulation, slow physical activity improvements, medical nutrition therapy, to have wholesome diet with less of saturated fats, less of calories, and less of course, the salt. Cardiac rehabilitation should be done, because patients might require a change in the occupation after the MI, and they may need to have to be rehabilitated in a way that they are productive. Periodic follow-up is essential. At least they must be seen in the first 1 month at least twice, then thereafter at least once in 3 months the patient must be followed. What are the complications of acute myocardial infarction? Acute myocardial infarction can throw in many types of complications. The commonest one will be extension of ischemia. Ongoing ischemia, extension of the infarct. It started as a small infarct here, it is extending. Second dreaded and most important complication is of course electrical complications, arrhythmias. They may be benign arrhythmias like ventricular ectopics or atrial ectopics or simple conduction defects, or there may be malignant arrhythmias like ventricular flutter, ventricular fibrillation, uncontrolled ventricular tachycardia, and other conduction disturbances. Pericarditis is a complication of acute myocardial infarction. The pain will not regress, there will be ST segment elevation may be there, but of course you have a pericardial friction rub can be heard. The pleuritic, pain will be pleuritic in nature here, and whenever he takes deep breath, he will have pain. Right ventricular infarct should always be thought of in a case of acute myocardial infarction, because RV infarct is always associated with inferior wall infarct, and the prognosis in RV infarct is poor because of the poor right ventricular output, and there will be hypotension. So we need to select out these patients because they require early reperfusion. Nitrate should not be given, and they should not be put on diuretics. Mural thrombus, because once there is the infarct is there on the infarcted surface, endothelial surface, there can be formation of thrombus, and this mural thrombus may get detached and produce embolic complications. Of course, mechanical complications like rupture of the ventricular septum, rupture of the papillary muscle, and then there may be VSD, there may be ischemic MR, or there may be an aneurysm formation, and there may be expansion of the left ventricle and aneurysm formation. These are some of the mechanical complications. The most dreaded complication, of course, is heart failure, and based on Kilip class, we can classify it as class 1 to class 4, and cardiogenic shock is very fatal with severe heart failure. So these are the most important complications of acute myocardial infarction. So we have seen this in the previous slide in the diagrammatic form. Here they are listed here: recurrent chest pain, post-infarction angina, ongoing ischemia, acute pericarditis, Dressler's syndrome, and then arrhythmias, that is transcutaneous pacing, transvenous pacing may be needed, or intracardiac devices may be required. Cardiogenic shock is a special entity to be discussed. Mechanical complications like aneurysm, pseudoaneurysm, free wall rupture, papillary muscle rupture, ventricular septal rupture, and VSD. Treatment related complications like bleeding and heparin-induced thrombocytopenia, also known as HIT. What is cardiogenic shock? Evidence of hypoperfusion in the form of oliguria, cold clammy skin, especially the hands and feet, impaired mentation, systolic blood pressure less than 80 or 90 millimeters, LV end-diastolic pressure or pulmonary capillary wedge pressure is increased and it is more than 18 millimeters of mercury. Evidence of primary cardiac abnormality in the presence of these signs, there will be primary cardiac abnormality like an STEMI, and then cardiac index is less than 1.8 liters per minute per meter square. That is, the cardiac output is so reduced that cardiac index is less than 1.8 liters per meter square per minute. IABP, intra-aortic balloon pumping, and full inotropic support is essential for all cases of cardiogenic shock. The prognosis is rather poor, 60 to 80% mortality in those who present with cardiogenic shock.